over to Purendra, who's at Gwalior, again a great surgeon and one of the maximum number of surgeries that is being done in that region. He'll be talking about posterior polar cataract. Thank you, Purendra.
Thank you, everyone. And posterior polar cataract is definitely an enigma for any ordinary or any proficient surgeon. So it is the incidence is from 3 to 5% in 1,000, and bilateral involvement is seen in 65 to 80%. We should think of when you see a case with the PC rent, central PC rent, then you should think that in other eye there might be a posterior polar cataract, because these are bilateral most likely. And the important thing with this posterior polar cataract, which has to be remembered, is that there is a pre-existing defect in the posterior capsule, or the posterior capsule is fragile. So this is the morphology, this is the look of these cataracts, and bullseye or onion ring, what they say. And it predicts the intraoperative behavior. When you see on the slit lamp, that will tell us how this cataract is going to behave during the surgery, whether there will be a pre-existing rent, or rent will occur when you are doing irrigation aspiration or doing the Phaco procedure. So it is challenging because of the weak pre-existing posterior capsular defect, and there is a high chance of posterior capsule rupture. And the PCR rate can be, which has been published, is 0 to 36%, but it can be anything. Even in the experienced hands and everyone, the rent can occur in these cases. And we should plan all these cases, as you saw that 35% you get a PC rent, but we should assume that all these cases are having a weak posterior capsule, so we should presume and perform the surgery by thinking this kind only. So it's not going further. Oh. It's not moving further. So one second. Cancel karo. So the important thing which we can assess beforehand is by doing ASOCT or pentacam. As you can see, you can make out there is a posterior cone in the pentacam imaging, sham fluke imaging, or there is a kind of a moth-eaten or irregular posterior capsule, as you see on the bottom pictures. These are from our own pictures from our own pentacams. So hydrodelineation is the cornerstone. So the most important thing is fill the chamber with viscoelastic and do the hydrodelineation, which is the cornerstone, which is the most important thing. You never do hydrodissection in these cases. A thick, and this golden ring should be there. Many ways of doing hydrodelineation has been given in the literature, Dr. Vasavda's technique from inside out and others. The only thing what important is to be remembered that there should be a thick posterior the cortex sheet or epinucleus sheet, which will prevent the rent to occur. Now we should keep low flow, low vacuum parameters, avoid sudden chamber shallowing. So always fill the chamber with the viscoelastic before you remove the irrigation handpiece, and ensure watertight incisions that should match with your instrument, the side port incision. Closed chamber dynamics throughout the surgery. Stability is very important, and nucleotomy, we should not rotate the nucleus fully, just disengage from the epinucleus plate and leave it there, and as far as possible. And lambda and Y techniques are suggested that can be done. But what I do is I remove the central nucleus first and then epinucleus slowly. So posterior epinuclear plate is preserved until the end. And visco dissection or could be done, or you can use the iris spatula and release the adhesions of the epinucleus plate, and you can bring it to the anterior chamber. Cortical aspiration should be done from periphery, and the central part, which is the area of mouth-eaten appearance, should never be touched. Even if you see, and maybe you can touch it after you have implanted the lens. So this is the case, young patient, and having a posterior polar cataract. And all these patients, their quality of vision is very poor. So they always come forward for the early cataract surgery. So the hydrodelineation is done, and a band of epinucleus is left over, and then this is a soft cataract. So remove the nucleus, which is soft, and I use this iris spatula to release some the epinucleus sheet from the undersurface of the capsular access rim, and the cortex is aspirated from periphery towards the center, and do not touch the central part and till you have implanted the lens, or rather you can do early yak capsulotomy in the postoperative period and fill the chamber with viscoelastic, and the lens is placed in the bag. So this is the way it should be done. Another case, slightly more denser nucleus and a typical posterior polar look with the bullseye appearance. Capsular axis is adequate sized. Various types of capsular axis has been suggested. I think the routine capsular axis size is okay with all these cataracts. Oval capsular axis and many other types have been described. And then you chop it as if it is possible, the nucleus, and gently rotate it. Because the speed is more, that's why you see it is 2x, that's why you are seeing it fast, but it has to be done all in a very gentle way. My posterior plaque is still there, and I am releasing with the viscoelastic cannula from the periphery. Never touch, don't ever try to touch the central part of the posterior capsule. So the sheet is pulled out from the periphery towards the center, and some moth-eaten appearance will be visible. Some flecks of PC are on the posterior capsule, bread-eaten kind of bread crumbs kind of things are visible. Don't touch them, because the moment you are going to touch, the lens capsule is very fragile and it is going to break. So the lens is placed inside. This is Flux helps us in many ways in these cataracts. Just one last video, and hydrodelineation, similar thing. So this helps us in the nucleus debulking in the center, and central piece is removed with the Phaco, and after this, friends, so sometimes we can land up in the PC rent in these cases. So as has been mentioned by Dr. Ramamurthy, how to manage these cases. Key take-home message is posterior polar cataract surgery demands anticipation, not the reaction, and weakness is the root problem. Strategy matters more than machine settings. Controlled Phaco can achieve excellent outcomes. Respect the capsule, and it will respect you back. Thank you.
Thank you very much, Purendra. Yeah.
Sir, it is my only clarification.
Yeah.
See, you said PCO.
CO.
After emulsification, everything is being emulsified. If it is a capsular cataract, definitely it will not be emulsified. It is a cortical cataract, posterior cortical cataract. PCO, capsular, it cannot be emulsified. This is, I request your clarification. Thank you.
This is a posterior polar cataract which involves the posterior capsule mainly and some part of epinucleus, the posterior part of epinucleus. It involves the posterior capsule. You can see various studies are there, various pictures are there which depict, which tells us there is a pre-existing weakness in the posterior capsule or there is a dehiscence in extreme cases.
Any treatment from your side for posterior capsular cataract, sir, not
Any
for
precaution?
cortical cataract.
Posterior capsular cataract.
Yeah.
So this has to be differentiated. They are simple. They can be managed by the simple way. But this posterior capsular cataract, posterior polar cataract are different from posterior capsular cataract.
Okay.
Thank you very much. Thanks, Purendra, for an excellent presentation. We go to next young dynamic.
Hello.
Okay.
Any
Please
parameter
can
change?
Yeah, fast.
Femtoparameter in posterior polar cataract?
Parameters in polar cataract.
Yeah, low vacuum setting, low parameters should be used.
So far the flex is concerned.
You're talking about what?
Flex.
Flex or routine, anything.
And
Flex,
posterior
it
safety
always you require less energy in flex.
Flags में
posterior safety
parameters.
margin?
See, your question is
Posterior safety
offset
margin,
is on
whether-
visualization. You visualize up to which level the defect is going and you raise it 500 microns above that. आपको defect दिख जाता है उसके ऊपर लेके जाइए. That's about it. Thank you very much. Thank you, Purendra. We are running short of